Order, order. Paul Bristow to move the motion. Paul.
Formally moved. Thanks, Sir Gary. It's a pleasure to serve under your chairmanship. I would also like to draw members' attention to my entry in the Register of Members' Interests. Our NHS is in my DNA. Both of my parents were nurses and worked in the NHS all of their working lives, well, for most of it anyway. And it was the NHS that brought my family to Peterborough when I was just 5 years old. And I've worked in NHS policy for 20 years. My commitment to our NHS and its principles are clear. Now, few things inspire as much national pride as our National Health Service, and I want to keep it that way. The NHS has lost its ranking as the best health system in a study of 11 rich countries by an influential US think tank. But most worryingly of all, it fell to 9th when it came to healthcare outcomes. And we need to do something about this. We need to ensure that this record investment that we're putting in our NHS is spent well. And I would like to suggest that this money should come with some very specific key performance indicators, KPIs, that would ensure that this money is not wasted. And this is something that I feel strongly should be in the gift of ministers through the Department for Health and Social Care, accountable to Parliament, rather than NHS England or NHS Improvement. Like the Department for Levelling Up Housing and Communities would do with a local authority that doesn't do what it should do, that it wouldn't run a balanced budget or provide statutory services. We're talking about direct intervention, or at least an incentive, that they would not get their share of this extra cash in the fear that it would be wasted unless they address the challenge of access to care and improved outcomes. And I'm keen to help ministers. And I almost feel, sort of thwarted, because progress on many of the things which I spoke about at the party conference last month have started to be reflected in government announcements. And this is good. It's obviously a good thing. But for me, this needs to come with strengthened incentives to do the right thing, and quite honestly, consequences for not doing the right thing. Now, the first area we need to make progress is on local NHS management. Local government have been made to make a series of savings in recent years. Armies of local government managers, all doing the same jobs in neighbouring local authorities, have been an easy target for those defending the interests of taxpayers. But it can be argued that local authorities have done rather a good job of sharing senior officers. So the Chief Executive of Peterborough City Council is also the Chief Executive of Cambridgeshire County Council. And as a former Hammersmith and Fulham councillor, I also remember the Tri-Borough Shared Services Agreement in West London between Westminster, Kensington and Chelsea and Hammersmith and Fulham that was signed in 2011 that saved over £33 million in just 4 years. Now, Labour-controlled Hammersmith and Fulham petulantly took their toys home a couple of years later, but the by-borough arrangement is still saving the taxpayer millions. And I know that this practice is replicated across the country. But in our NHS, this practice is unheard of. Why? There are no reasons why officers and back-office functions can't be shared between NHS trusts and between new integrated care systems. So let's do away with every NHS trust having its own specific CEO, or its own specific director, finance director, or its own HR director, or its own estates director, or its own diversity director. I don't consider it controversial to ask our NHS to learn from local government. And if certain localities can't make these management savings, if they're unwilling to share back-office functions, if they can't look to make savings, why would we give them the extra cash? So perhaps I could suggest a KPI on a reduction in management costs and back-office costs. I think that would be warmly welcomed by the taxpayer and warmly welcomed by those in our NHS who know that money is wasted.
Thank my honourable friend for giving way and draw the colleagues' attention to my declaration of members' interests as a practising NHS doctor, but would he also agree that one of the challenges is attracting in good expertise, perhaps from the business world, into the NHS, and that sometimes might cost money and resources? And whilst he is wishing absolutely correctly to make savings in back office costs, that we need to not be too prescriptive in the ask on that, because we need to actually make sure we have the best people coming into the NHS, both from within and without, to deliver the productivity gains that he desires.
Paul Bristow.
Well, my honourable friend makes a characteristically very well-made point. But I would also argue that the current system, where NHS chief executives now spend 18 months in one trust and then travel to another, and 18 months in another trust and then travel to another, that's no time at all to get to grips with some of the challenges that these organisations face. And absolutely we need people from the private sector to come in and do these jobs. But if they're doing these jobs on a larger scale, I think that would be something which would be welcome. So what I'm specifically requesting is that perhaps we look to local government where people like you've suggested have come in and transformed services. We do the same in our NHS. The second point I want to move on to is innovation and new ways of working. And because innovation is the way an organisation develops. I mean, this should be a constant process, trying to do things better, improving outcomes for patients, and trying to be more productive. And across the NHS, there are those that innovate with new technology, there are those that adopt new pathways and service delivery, and there are clinicians that want to train and to learn new techniques. But the NHS can be poor at spreading best practice at pace and scale. Like any bureaucracy, it can be slow at looking at the new ways of working. And there have been attempts to address this, because we spent millions funding organisations like Getting It Right First Time, GIRFT, under Professor Tim Briggs, which is a national programme designed to improve the treatment and care of patients and collect best practice. And we created the National Institute for Health and Care Excellence, which at the time was considered, when it was created, was considered to be a model for the world to emulate on determining cost effectiveness of technologies and drugs. And it also produces quality standards that set out priority areas for quality improvement in health and social care. But after all this work is done, after all this money has been spent, many parts of our NHS just ignore them. They say things such as, this can't possibly apply to us, or this is merely guidance and we don't need to do this here. The use of insulin pumps, implantable cardiac defibrillators, or vascular technologies shouldn't depend on where you live, but they do. The solution is certainly not reducing GIRFT's budget from 22 million to 10.8 million, but this has happened. In fact, GIRFT should be empowered to develop best practices in primary and community care, and we should certainly look at the GIRFT model of hot, emergency, and cold elective centres in order to help us power through the backlog. So what is the solution? How do we make outliers adopt best practice and do the right thing? Again, a KPI, and perhaps even GIRFT or NICE can help us here, on technology and pathway adoption could transform productivity and help us power through the backlog. Backed up with an incentive such as a generous and workable best practice tariff, this could focus attention. And if they persist in practice that was being shown to be outdated, follow pathways that do not lead to optimal outcomes, again, why would we give them the extra money? And on capacity, staffing is recognised to be a risk factor in delivery for our NHS. The money is there, but it takes a long time to train a doctor, a GP, a nurse. That is why every hour of a medical professional's time is valuable. We have to make sure they are doing the things that they are paid for and what they went into medicine to do. Well, I certainly will.
He's making a fantastic speech, and I'm grateful for him letting me make an intervention. Would he agree with me at exactly that point, that every hour of a clinician is valuable? The average clinician loses about 10% of their workload simply chasing letters or following up blood tests or trying to find scans, which is a complete nonsense in our current system. It could easily be ironed out by joining up simple IT between primary and secondary care. Does he think this might be a KPI that he could support?
My honourable friend is a champion for efficiency in the NHS and within his profession, and he makes these points regularly in our meetings of the Health and Social Care Select Committee. And he has perhaps read my speech already, because I think the Winter Access Fund, I think, is an excellent start. I think it's an excellent start. It will address that many GPs have rightly complained about for some time. The fact that they spend so much time on fitness notes, on chasing appointments, and something else really, only something I realised when I met GPs in my constituency. And I just want to give a quick shout out to the super Dr. Neil Moder and his team at the Thistlemore Surgery, who do such a fantastic job with a very challenging catchment area. But it's the length of time they spend providing medical records to insurance companies and to other bodies. This just isn't their job. And the length of time they spend, but we need clinicians to practice at the top of their licence. We need GPs seeing ill patients, not prescribing things a nurse could easily do. Nurse-led prescribing has been around for a long time, but it's not been rolled out across many areas in which it should. And we need a revolution in physician associates and nurse-led prescribing, which will free up GP time, consultant time, to do the things that they need to do. Because that same waste of clinician time takes place in secondary care. We need surgeons in the cath labs or in the operating theatre using their skill. They shouldn't be there one day a week just in theatre. They need to be there multiple days a week, every week. And I hope surgical hubs and other initiatives will help. But I fear without a strict KPI on clinician time on highest skill, highest value activity, and I'm not opposed to this being backed up with some sort of financial incentive, but if this doesn't happen, then I'm afraid we won't make those savings in clinicians' time that we need to. Only with a KPI like this, together with an effort to demonstrate how valued our clinicians are, will we ensure that their valuable time is not wasted. And if an ICS or the management structure at an NHS trust can't or won't do this, then make it dependent on the extra cash. Now, just finally, much of this is dependent on greater transparency. And I was very pleased to hear the Secretary of State for Health and Social Care say at the Select Committee this morning that we're going to be able to see more data relating to the performance of GP practices. This also needs to happen with ICSs. In the past, many CCGs in the country could be guilty of hiding commissioning policies, rationing hip and knee surgeries with those with BMIs below 30, or even 25 in a handful of cases, on page 145 of a 278-page document on a website that no one ever reads. And NHS England are just as guilty of doing this with national service specifications and commissioning policies. And politicians have very little means of challenging this, as politics was taken out of the NHS. We need to open up the windows and let the light in. Accountability and transparency have always been the way to improve performance and efficiency. So let's have the Ofsted-style rating for ICSs and other NHS bodies. Let us know who does well and who doesn't. And together with clear KPIs, transparency and accountability, we can ensure that this record cash injection that my constituents applauded is spent well. The NHS is a source of national pride, but performance post-pandemic can and should improve. I offer ministers a few ideas, a few acorns on how we might do this.
Thank you. The question is that this House has considered NHS efficiency. Dean Russell has a few moments.
Thank you, Sir Gary. It's a pleasure to speak under your chairmanship too, and also an absolute honour to follow my honourable friend for his excellent contribution there. I would also refer to my registered interests. In particular, I wanted to raise the fact I'm the chair of the Digital Health All-Party Parliamentary Group, which very much informs some of my points today. I'll be very brief, because I'm conscious this is a big debate in a small period of time. But one of my passions for looking at efficiencies within the NHS comes from my own experience. About 12 years ago, I was asked by the Department of Health to do a strategic review of every NHS website in England and Wales. And I'll cut to the punchline of that story, that there were over 4,000 live sites. I did the financial calculation myself, and it worked out that it was between 87 and £121 million a year being spent on websites, many of which people didn't even know existed. And it highlighted to me that one of the challenges for the NHS is that because of its immense scale, even though people want to do the right thing, when there's duplication, that inherently causes extra costs on a scale that one can't really comprehend even in a normal business or even in a global business. And I think for me this highlighted various points. First of all, that actually if we want to improve efficiencies, we also need to make sure at the very heart of that is the patient experience and patient care. Having 4,000 websites at that time, which I remember several hundred all had, were about stopping smoking, it probably would have been more efficient to have one really good stop smoking website rather than 200 average ones. And the patient experience on that is not just about the outcome of that, but actually how do you find the right information, how do you get to the source, but also how do you make sure you're not repeatedly saying the same thing over and over every time you go for an appointment. And I think this is where technology is so important, because we often think of technology in the NHS as these big lumbering IT systems, these huge, expensive systems that are hard to even comprehend. But actually the world's changed. We've got a consumerised approach to healthcare now. People have watches that can track their heartbeat. They can go online and do emails for appointments. They can go onto apps and do so much more, even track their COVID status. So we need to look at the future, not just in terms of efficiencies for cost savings, but also in terms of patient experience. And if we can look over the next 10, 20 years and look at actually what sort of experience do we want patients to have, and my take would be that it's got to be at the heart of it seamless and efficient. Seamless in the sense that if you break your arm, you don't have to tell someone that you've broken your arm every time you see a new clinician, every time you go onto a new website or use a new app. That if you break your arm, that actually there might be a fact that you might need some additional wraparound care at some point in the future. It might affect whether you can work. Therefore, what's the impact of that in terms of social care? If we start to look at patients at the heart of what we do, we can create efficiencies around them rather than require them to duplicate their efforts as well as those of the NHS. And if I may, given the constraints on time, I would like to say one other point on this. There's a great opportunity here to re-look at what that patient experience is, given the technology that's available, not just in the NHS, not just in social care, but within the world of technology generally. We're so used now to using social media, we're so used to using apps, to use our phones for so many different things. If we can start to bring that into the fold of how we look at the future of the world of health, I think we've got a really powerful opportunity to say to patients, what would you like your health system to look like? Not just what health system looked like for the past 40, 50 years and impose variations of that on them, but actually what is it you as an individual would like to see in terms of looking after you, after your children, after your parents, not just now, but for decades to come, and then create a system that's efficient, that's effective, that has patient outcomes at the heart of it, but ultimately creates a superior patient experience that helps everybody, and as I would always say, quite rightly, free at the point of use to make sure that the NHS continues to live up to its values that it always has done. So that's my closing point there, is just to say, let's look to the future, look what's available, and let's not just rely on what we knew from the past. Thank you.
Thank you very much indeed. Minister to respond, Gillian Keegan.
Thank you. It's a pleasure to serve under your chairmanship, Sir Gary. And I welcome very much the idea of this debate and the timeliness of this debate as well. My honourable friend, the member for Peterborough, has raised a very important issue, and also many of the members in the room who I know have great experience of various parts of the NHS, and that includes the members for Watford, Bosworth and Central Suffolk and North Ipswich. So thank you for your contribution to the debate. Of course, we all have a responsibility to taxpayers to make sure that the NHS uses its resources as effectively as possible. To do that, we need to ensure that productivity grows every year. And that's why the NHS long-term plan includes financial tests too, which states the NHS will achieve cash-releasing productivity growth of at least 1.1% per year. And I want to be clear what increasing productivity means. Increasing productivity doesn't mean making staff work harder or making cuts. Productivity means getting the most out of every pound the NHS spends, and as much as possible is spent on frontline care. It means doctors and nurses doing the tasks they are trained to do and that nobody else can. It means buying the right drugs at the right price. Increasing productivity means that more patients get the right treatment in the right place at the right time. It's good for patients, good for clinicians and good for the taxpayer. And thanks to the hard work and innovative mindset of many NHS staff, the NHS is regularly recognised as one of the world's most efficient health systems, although I do take my honourable friend's point, there are different ways of measuring this globally. In fact, in the decade before the pandemic, productivity growth in the NHS was faster than for the wider economy, as independently verified by the Office for National Statistics. Furthermore, the UK spends only around 2% of healthcare expenditure on administration, and now we do spend a lot on the NHS, but only 2% of it on administration, and managers make up only 2.6% of the 1.35 million strong NHS workforce. They might be an easy target for criticism, but good managers, of course, are essential to making services work, and many of us will have had experience of that throughout our various careers. If there were no managers, clinicians would have to manage their own workforce, logistics, finances, websites, and spend less time with patients. Nonetheless, we do want to improve the quality of management further, and that's why we've asked General Sir Gordon Messenger to lead a review of leadership in health and social care. Very happy to give way.
Declaration of members' interest in practicing NHS doctor. But just on that point, of course, we also want to promote clinical leadership in the NHS in senior management positions, because that, we know, benefits patients and leads to efficiencies. But we also need to look at the fact that there are many good NHS managers, but a lot of them have never had experience of life outside of the NHS. And I just wondered if my honourable friend could briefly turn her remarks to how we can promote better, drawing in better business experience and other experiences, so that NHS managers have a broader experience, so they can bring that benefit to the NHS and drive efficiencies.
Yeah, I thank my honourable friend for his intervention. Actually, I've heard exactly the same point applied to many different industries, even indeed politics, right? How many people come into from business to politics or politics to business? That crossover between public sector, private sector, bringing those skills and actually learning from each other is something I don't think is done nearly enough, and that's why I spend a lot of my time actually trying to get more business people involved in politics. But I'm sure it is a challenge for people to do that, because you do tend to get, I guess, stuck in the way that you know, and you tend to, go up the career ladder in the world that you know, and there is too little. And also, I guess, the recruitment companies have something to answer for here. They look for square pegs and square holes, people who've done what they've already done, and it's a natural progression. But I think we do need to encourage that. And I do find if you put out a call and say, actually, we really do want some business people to come and help us join, then I'm sure many business people would be interested in their second career in public service, as we're all doing here as well. As I say, Sir Gordon Messenger will look at reviewing the leadership, and he has the terms of reference for that are being developed right now. I think there's no doubt that COVID has had a severe impact on NHS productivity. COVID significantly increased the cost for the NHS, whilst we had to stop some regular activity, so the productivity was obviously much, much less. Many patients indeed did not even wish to attend the in-hospital services. And of course, COVID made more stringent infection prevention and control measures necessary. And these measures, such as putting on PPE, taking off PPE, slow staff down, limit the number of patients they can see, and will probably continue to hold down productivity for the immediate future. And we know that with red zones, green zones, and new processes to try and manage infection control during this period. We don't yet know what impact COVID has had on NHS productivity, but we do expect it was large and it is negative. The ONS estimated public service productivity as a whole fell by 22.4% between July and September 2020, compared with the same quarter a year earlier. And then even as it recovered, productivity was still less, still nevertheless 9.8% lower in Q1 2021 compared with Q1 2019. So COVID has definitely had a massive impact on productivity. It is reasonable to expect that the impact on the NHS productivity would be similar to that. But at the same time, the pandemic has been a spur for innovation. Across the NHS, clinicians said that the pandemic offered an opportunity to cut through bureaucracy, try new ways of working, try new ways of partnering with local services as well. In London, hospitals work together, and as my honourable friend mentioned, they're Getting It Right First Time programme to pilot a new approach to high volume, low complex surgery. And that is now being rolled out across the NHS. And my honourable friend mentioned budget numbers, but it's not really easy to compare like with like because it's being integrated into the NHS improvement budget as well. And the programme is now embedded within that plan for elective recovery. So that's where the finances are coming from. Trusts will be benchmarked against the programme standards for surgical productivity through the model hospital system. And NHSEI set up a beneficial changes network to collect evidence of innovation during the pandemic. Now, this network has distilled 3,000 submissions and 700 examples of recognised beneficial changes into 12 high-impact change areas. And these will now be rolled out the NHS as well. So that's been something that's come out of the pandemic from that need, really, to really work together to face the challenges we were facing. Now, as the NHS begins to recover, increasing productivity is more important than ever. Many patients couldn't receive the care they needed during the pandemic, and the NHS faces unprecedented waiting lists. We owe an immense debt of gratitude to the NHS staff who have worked so hard to care for patients throughout the pandemic. But the NHS now needs to use the investment that we provided to deliver more care more effectively and remove the burden from staff. This year we're providing £2 billion through the Elective Recovery Fund to increase activity levels and £700 million through the Targeted Investment Fund to fund improvements in surgical productivity and digital productivity tools. And digital will be a big feature, of course. We've all learned a lot during the pandemic. We've also announced a further £1.5 billion to build surgical hubs across the country to develop the new models of care and increase productivity, which is piloted by GERFT and the London region. £2.3 billion has been allocated to transform diagnostics, rolling out at least 100 community diagnostic hubs and investing in digital diagnostics that will deliver 10% higher productivity. £2.1 billion to digitise frontline services and free staff from admin tasks to spend more time with patients, something that was mentioned by the Honourable Member for Bosworth. And our aim is to return productivity to an ambitious trajectory so that we can deliver on our ambitious plan to build back better, to clear the waiting list, but also to build an NHS that is fit and able to cope with the demands of the future. Of course, we have more work to do with integrating social care and looking at how we can develop best practice so that those systems work very well together. It's not over. We've got a lot of work to do, but I feel sure that with all the measures that we've put in place, my honourable friend will feel satisfied that the NHS is continuously looking at continuous improvement. Thank you.
Thank you. If Mr Bristow wishes to have 30 seconds to finish off, that's fine. Paul Bristow.
Thank you very much, Sir Gary. And I would just, I am impressed with the Minister's response that she has talked a lot about how the NHS is going to improve efficiency and productivity post-pandemic. I would just like to just remind her of the plea I made at the very end, because the key to this, I think, is transparency and accountability. And if we don't open the windows, we let the light in, then I think it's often, all too often, your ambitions, the government's ambitions, won't be realised and money will be wasted through other means. So let's try and create as transparent NHS as we possibly can and accountable to ministers. And then I think we might be able to see some of the changes that she talked about in her speech.
Thank you very much. Questions that this House has considered NHS efficiency. Has made that opinion say aye. Somebody help me out here. We'll continue no. I think the ayes have it. The ayes have it. Order, order.